My name is Nick Crofts. I'm a Professorial Associate Fellow, rather, at the University of Melbourne at the School of Population and Global Health. And I'm an honorary Executive Director of the Global Law Enforcement Public Health Association. And I want to talk to you a bit about what the Law Enforcement Public Health Initiative is about. But I thought I'd start off with a bit of background about how I got into working with police. I'm a public health person. In fact, I was a community health doctor for the first part of my career, and got into epidemiology around about the same time that HIV appeared. And a large part of my career was working with HIV among injecting drug users, which I'll talk about a little bit. One of the very few good things that came out of the COVID epidemic is that everybody learned what an infectious diseases epidemiologist is. And I'm in professional training in infectious diseases epidemiologist, which took me to England in 1986, working at the Communicable Diseases Surveillance Centre, and then in the AIDS branch at CDC in 1987 in Atlanta. And interestingly, even though at the time in America, HIV was spreading rapidly and catastrophically through populations of injecting drug users, there was nobody in the whole AIDS branch at CDC who was working on the issue of HIV among and from injecting drug users. And that was when I first came across the degree of stigma with which people who inject drugs are afflicted. So I got interested in it. I worked in Tacoma, in Seattle, for the health department, where I ran across the first needle syringe program in the United States, started by a bloke named Dave Purchase in Tacoma. Through him, I met another bloke named Aaron Peake, who started the second legal needle exchange in the States in Hawaii, then decided that was too easy and went to Asia to start needle exchange in Asia, ended up in Kathmandu with the first needle exchange there, which I got involved in, and that got me involved in working in Asia. And spent a lot of time working in Asia. I was at the Burnett Institute, came back to Burnett Institute from CDC in 1988 and ambitiously got my first NHMRC grant, which was for a field-based cohort study of injecting drug users. Little did I know how engaging and difficult that was going to be. Over a period of about 5 years, we followed something like 1,000 people who inject drugs in the field looking for HIV as the endpoint. But as you well know, Australia was so successful in the early days in stopping the spread of HIV that I didn't observe any HIV spread amongst my cohort. And my research career was going down the drain because there were no endpoints. And then along came hepatitis C and I was saved. So did a lot of research work on the epidemiology and control of hepatitis C. And at the same time, working in harm reduction in Asia, working in policy development, implementation, program implementation, research, advocacy across pretty much every country in South and Southeast Asia. Work in Asia, very early on, I came to the realization that if I was going to work in countries like Cambodia or Burma or China, if I was going to work with marginalized communities like drug users or sex workers, I had to work with police and public security. Everything to do with sex work or drug use was with public security. Everything to do with AIDS was with public health, and the two didn't talk to each other. I ran a workshop for 10 senior public health and senior public security officials from all around China in Guizhou in Guiyang province in 1995. And I learned that one of the lessons I learned there was that we had a mixture of public security and public health people, senior public health and senior public security, but we resourced it only with me. And for a week, I gave them harm reduction 101, HIV, and so on. And the public health people were quite interested. The public security people went to sleep. What did I, a public health person, have that would be of interest or relevance to the public security police people? And I learned then an absolute need for working with police. Getting police engaged in the HIV response has been a huge challenge because they are seen, and with justification a lot of the time, to be the enemy of prevention efforts, barriers to prevention efforts. But where you can get police engaged and involved and supportive, you can do a lot of things that you can't do when they're the enemy. AusAid, we used to have an aid agency here in Australia called AusAid, and they had a flagship regional HIV program. And in 2000, 2004, we ran the Asia Regional HIV project, which was in Burma, China and Vietnam, looking at getting police engaged in the response to working with drug use. And the lessons we learned out of that and other work were that in those situations, if you don't work with police, you don't work. And if you don't work, nothing changes. And the devastating toll of HIV, amongst many other things, goes on amongst those marginalised communities. The practical learning of working with police came down to a few questions, which I think are very relevant if you're looking to form working partnerships with police. The first question is, what's in it for them? What's the self-interest? And it's not that police are unique in that goes for anyone, but finding out what's in policing as a particular culture. I've been working with police now for 30 years, and I'm still not part of the culture, and I still don't know it from the inside. I'm still learning. But how do you get them? You can't get them to do your job. You can't ask the police to be involved in drug treatment or involved in HIV prevention. That's not their mindset. That's not their purpose. So how do you get them to do our job, but for their reasons? That's the clever part, I think. And I think we were very, very successful in getting police, for instance, getting methadone introduced into Vietnam. Methadone, I know of at least 6 attempts to get methadone introduced into Vietnam over the years, all of which were failures because it was advocated for and brought in as a health measure among injecting drug users, amongst heroin users. And the public security in Vietnam, Ministry of Labour and Social Affairs in Vietnam, question was, well, why should we be spending, primary healthcare money on people who are basically enemies of society, these drug users? But once the message was sold that methadone is a good crime control mechanism, and once the public security people started to see pilot methadone programs in Hanoi and Hoi An and Haiphong bringing down the crime rate, they became fervent advocates of methadone. So how do you get them to do your job, but for their reasons? And peer education amongst police became fundamental to the way of working. I can't remember who it was told me, but a senior police officer talking about getting police to support harm reduction put it this way: a third of them get it, a third of them could get it, a third of them will never get it. Your job is to work with the third who get it, to bring on board the third who could get it until you surround and outnumber the third who'll never get it. And I think that stands as a bit of a slogan for working with police generally and working with police cultures. I've not yet met a police agency anywhere in the world where there aren't at least a few police who want to do things differently and others who are open to doing things differently. And it brings home the fact that changing police cultures is like changing any other culture. It's a long-term process, probably a generational process. But the other thing I learned the next thing I learned working in Asia was I didn't know how to work with police because nothing in my public health training had taught me about either the role of police in public health or how to work with them. And I'll talk about this in a minute, but it's an extraordinary oversight. The world of public health, organised public health, academic public health, pretty much ignores the role of police in achieving public health goals. And the more you look at it, the more it becomes a puzzle because as you start to look at it, you realise that police, law enforcement sector generally, police in particular, are critical in achieving a whole range of public health goals. My friend Scott Burris at Temple University had the best article title, I think, that I've seen for a long time. I'm very jealous of: The Mysterious Case of the Missing Cop. Where's the cop in the public health team? Public health prides itself on being the most multidisciplinary profession that there is. And that's just one example. That list there is just one example from the Public Health Agency of Canada, but I collect these. I've got dozens more from World Health Organization, from Johns Hopkins, from Schools of Public Health, London School. The list of people involved in public health is endless. Nutritionists, town planners, everyone. But I have yet to find one that includes police. And I've yet to find a Master of Public Health course that teaches about the role of police in achieving public health goals. Why? I don't know. I have some thoughts about it, which I'm happy to talk about later, but not really relevant. But the challenge is to redress that and to. I'm not telling this group anything they don't know in saying that involvement with the criminal justice industry is detrimental to health. I use the phrase criminal justice industry rather than system because for two reasons. One, I don't think it's a system, and two, I think it's got all the hallmarks of an industry that depends on taking raw material and putting it through to make a product to give people, a whole lot of people, a living. Criminal justice, involvement with criminal justice is a major social determinant of poor health over the life's course. Again, as I say, I don't think I'm telling anyone here anything that they don't know. And that involvement is, somebody hasn't got their microphone muted. That involvement is, as you well know, systematically inequitably distributed by race, ethnicity, gender, geography, poverty, all sorts of other factors that determine whether, with particular risks, you go into a criminal justice system or you go into a health system. And the gatekeepers largely are police, with other members of the law enforcement sector, including prosecutors and coroners and so on, as being also important as gatekeepers. Police actions have a huge impact on health and safety. We're all very aware of the detrimental impact of police actions, and body cams and mobile phones have brought home the police shootings of unarmed black men, usually in mental health crisis in the States. But that's just the most dramatic end of that impact, of that detrimental impact of police behaviour on health. However, police have also lots of positive impacts on a whole range of public health goals. How do we get them to work together to achieve public health goals and have outcomes that are consistently, uniformly beneficial across the whole of the community? And that's the challenge that the Global Health Law Enforcement and Public Health Association has taken up. The phrasing we use, and it's been a long debate about the phrasing, because law enforcement sector and the public health sector use language differently. What we have come down to is the idea that law enforcement and public health are both sectors and both activities. So law enforcement is engaged in public health activities, public health is engaged in enforcing laws, particularly through regulation. But unfortunately, most of the time they operate in silos. The other phrasing that we've adopted is a Canadian phrasing of community safety and wellbeing, that if you say to any police officer anywhere in the world, your job is to assure optimum community safety and wellbeing, they'll agree with you. You say that to a public health person and they'll agree with you too. So it's a meeting of the language. So I don't know if I've demonstrated it, and I can certainly talk more about it, but the basic bottom line is that police and other members of the law enforcement sector are public health actors, should be seen by public health as public health actors, and should see themselves as public health actors. The first attempt to try and get something going with police was the Law Enforcement HIV Network, and this was specifically around getting police engaged in the HIV response. Lean went on for I think about 15 years. We had never achieved funding. It was volunteers, police in agencies in low and middle income countries who we supported and trained to become peer advocates within their own agencies. And Lean produced a huge range of resources and had enormous impact across a whole range of police agencies. This is police at one of our conferences. Can you see my arrow? Does my arrow show up on that? Yeah. So Jones is from Ghana. Alex is from Kazakhstan. I forget her name, but she's from what's now Eswatini. Peter Jaap Aldersberg is the Chief Commissioner of Police in Amsterdam. Wilson was from Kenya. These are all senior police. Frank Hansen's a retired New South Wales detective, and he's signing a memorandum of understanding with Jimmy Doherty, who was at the time the head of the Asian network of people who use drugs. Lean produced a statement of support by police for harm reduction in 2012, which we then went around the world and got signatories to. We got something over 10,000 serving retired police to sign up, plus 25 police agencies, and had a big launch at the UN Crime Congress in Doha in 2013. A statement of support by police for drug policy reform was produced at our conference in Toronto in 2018 and launched at the Commission on Narcotic Drugs in 2019. Both of them aimed at breaking down the stereotype that police are prohibitionists. There are a lot of police who very sensibly see the idiocy of prohibition and wish to see different political and policy approaches. I'm happy to provide any of these resources to anyone who's interested. Jones is a special case. We did a video in 2014 of police advocating for police involvement in HIV responses, and Jones, who's is now an assistant commissioner in the Ghana police. In Ghana, as in a lot of other countries, police would stop women on the street and search them, and if they found a condom, that was evidence that they were engaged in sex work. Jones had a little leather pouch made, the condom pouch, which his police have to carry. And he says to them, if they are not carrying their pouch, they are out of uniform. And in that pouch are condoms. And his thinking is, how can the police arrest somebody for carrying condoms when they're carrying condoms themselves? And that changed the mindset of the Ghanaian police to the point where they actually started handing out condoms to sex workers. This here is the launch of the statement of support by police at CND. Neil Woods is the English representative of Law Enforcement Action Partnership, Law Enforcement Against Prohibition. Ron Hogg was a police and crime commissioner in Durham. He's unfortunately died since, but he was an ex-chief constable who became a police and crime commissioner in Durham and a fervent advocate of drug policy reform. And I'm sorry I'm racing so much of this. I've just put in too much to talk about. Peter Moysant is a serving commissioner of police in Antwerp in Belgium, who wrote a book called We Were Brothers, because his brother was heroin dependent and died of an overdose in his police patch. So out of Lean came the realization that advocating for police to be involved with drug users carried a huge difficulty, because police culture in many parts of the world at most times sees injecting drug users as enemy, as outside society. So advocating for them to support them, the drug users, meant asking them to do something that went against their culture. Public health, on the other hand, police, since the days of Robert Peel, police have been involved in public health. In fact, the original Peel's original police force was much less involved with catching criminals than with assuring public safety and well-being. So right since the institution of policing started, police are involved in public health. So advocating for police to work in public health, the easy ones are things like road trauma, diminishing the public health toll of road trauma. That, in many cases, is driven by police. And I always say I'm in the jurisdiction that started that. Victoria was the first jurisdiction in the world to have compulsory seatbelt legislation, compulsory motorcycle helmet legislation, and there is only one reason for it, and it's a public health reason. So we created, in 2012, we held the first International Conference on Law Enforcement and Public Health in Melbourne. That took off. We had a speaker from the Dutch police, and I'll talk about the Top 600 program in a minute, but they invited us to Amsterdam. So the conference was in Amsterdam in 2014, again in 2016. Many good things going on with police, looking at the broad picture of community safety and wellbeing in Canada. So we got to Toronto in 2018. And at that stage, we decided to go annual, because there's just so much going on in this space in so many different places around the world. So we're in Edinburgh in 2019. COVID hit. We had a virtual conference in 2021, and then started up again last year with a regional conference in 2023. And in 2017, in the midst of all that, we founded the Global Law Enforcement and Public Health Association. One of the intellectual drivers of this is what's happening in the UK, particularly in Scotland and parts of some jurisdictions in England, and basing it on the work around adverse childhood experiences that originally came from America, from studies at Harvard, but now informs this whole trauma-informed approach to policing and public health policing. And the The Scots talk about the pair of ACEs. So the determinants, the childhood determinants of what happens to you later in life in terms of your involvement either with a lot of health states, particularly mental health, or with involvement with the criminal justice system are identical. The processes that go into channeling you into one or the other, largely social determinants and socioeconomic determinants. The Scots talk about the pair of ACEs, that adverse childhood experience. The more adverse childhood experiences you have suffered, the more likely you are to have mental health problems, suicide, involvement with criminal justice, etc. But that can be worsened or ameliorated by the community environment you grow up in. Adverse childhood experience, I don't know if people on this webinar have been exposed to the idea of ACEs, but as I say, Scotland has announced that it is the first ACE-aware nation, and ACE, adverse childhood experience training, underlies the trauma-informed training that dominates Police Scotland training. The idea of what ACEs are has grown since those original studies to the point where it's probably becoming a little bit, what's the word, not boring, you know, a bit mundane, but the fact still remains. The top 600 model, I wanted to say something about. The Amsterdam police, some years back, started this model where at the end of each year, they look back at the 600 top users of police resources, who used the most resources of the Amsterdam police in the preceding year. There are some other qualifications like involvement in violent crime and so on, but having identified them, we then throw everything we have at them. So mental health counselling, drug and alcohol, employment, housing, get them out of the criminal justice cycle. Look at what the cause of the causes are of their involvement with criminal justice and get them out of it. And it works. It works brilliantly. It worked to the point where the Amsterdam municipality, after a couple of years, said, okay, top 600 is working, can you do the top 1,000? And one of the things I like about the way the Dutch think is that they didn't go for the next 400, they went for the 400 family members of the top 600, recognising that these phenomena are not individual phenomena, they're social phenomena. The Dutch prison rate has systematically been falling. I lived in Amsterdam for 6 years up until 21, and I watched the prison rate, this only goes to 18, but it continued downwards. The Dutch closing prison beds. And at one point, they were actually renting prison beds out to the Norwegians, but they're now closing prisons and prison beds. And I come back to Victoria to find the highest imprisonment rate we've had in this state since 1890. We get it wrong all the time. And again, I don't think I'm telling this group anything that you don't know, but responding to mental health, getting police to respond to mental health issues. I don't know if you remember this one. This was in Preston in Melbourne, when a psychiatrist asked police to do a mental health check on one of his patients. Why? And the guy ended up pepper sprayed on his front lawn, having a hose squirted in his face. There is a movement in the States that you all know about, defund the police and abolish the police. And part of the argument there is that there is police overreach into areas they shouldn't be. I've talked to a lot of police in a lot of jurisdictions around the world. I have yet to meet a police officer who wants to be responsible for responding to mental health calls. You will have seen in the news the Metropolitan Police in London refusing to take mental health calls, and that's something that happened in Saskatchewan in Canada too some years ago, because they're not trained. They're not trained, they're not supported, they're not resourced, they're not the right people. Police Scotland went through a big exercise reforming their response to mental health calls, and they now have dedicated mental health triage lines and a mental health response. So the response to a mental health crisis is not reliant on law enforcement. No, that's the Victorian data. And again, I'm not telling this group anything you don't know in saying that the one statistic that always gets me is that anywhere in the world, the major risk factor for incarceration is having been in prison before. And the numbers, again, are familiar to you all. The number of people incarcerated with mental health, drug and alcohol issues, and the big elephant in the room, the acquired brain injury. And to a large extent, organised public health saying, well, they're not our responsibility because they're in the criminal justice system. And working on the health of people in criminal justice is one thing, working to keep people out of criminal justice is what I think is the responsibility of organised mental health, public health. I mentioned England. In 2018, they came out with this. It's a 3-page statement about they call it the consensus statement. It's a 3-page statement about the need for public health and law enforcement to work together. And the reason I put this up is because these are all the relevant national agencies and bodies around from policing and from public health. Public Health England unfortunately doesn't exist anymore. Boris got rid of it. But the consensus goes on. The consensus guides a lot of what they do at local level, including the violence reduction units. There's something like 25 violence reduction units around England, one in Scotland, the original one in Scotland, all taking a public health approach to tackling violence. These grew up in collaboration with what happened in Chicago when they were looking at gang violence in Chicago and taking a public health approach to gang violence. When I did my Master of Public Health, which was 1985, we didn't learn about violence as a public health issue. That's relatively recent. Researchers at CDC who started looking at violence as a public health issue in the late 80s and then informing responses in Chicago, who were working with Glasgow and from there developing this idea of primary healthcare police, public health policing. I wish I could spend more time on this, and I'll come back to it in questions if you want, but I'm trying to get the Global Law Enforcement Public Health Association has a whole range of special interest groups, and one we've just started up is on trauma-informed policing. And we had a conference last week with Deakin University where we brought out a couple of people from England and Scotland who talked about trauma-informed policing, and quite a number of Victorian police were there. I don't know how many were online, but quite a number were there. And they found it very, very convincing. It's an approach that not only brings about better results in terms of your policing, but it's better for police. And I guess, again, I think everyone would be aware of the crisis that most police agencies around the world are going through, of having trouble recruiting and having high attrition rates. Until I started this work, I honestly was not aware of the things like the suicide rate among serving police. And what I've become aware of is that while we measure the suicide rate among serving police, and it's astonishing, we don't measure it amongst police who've left the force, and it's even higher amongst those. Trauma-informed policing is an approach that actually ameliorates the stresses and the violence towards police as well as towards their customers. What does trauma-informed policing mean? It goes back to, as I said, the roots are in the adverse childhood experience approach and understanding the social determinants of involved with criminal justice. But I asked a police officer in Scotland, okay, you've had your trauma-informed training. What does it actually mean to you on the job? And he said, well, previously, if I ran across somebody on the job, my question was, why did you do that? My question now is, what has happened to you that got you to this point? What can I do to stop you continuing down the path that you're on? And once I asked that question, I realized there's not very much that I can do. I need partners. And so the whole approach drives towards partnership. And that's the sneaky way of changing police, partnerships. We have been looking around the world at people developing innovative approaches to issues that really are public health issues that have been criminalised, or there's been an over-reliance on policing. We've had a couple of projects, and we just launched this series of reports looking at innovative approaches from the four corners of the world, dealing with preventing violence against women and girls. You can read the titles yourself. Diversion programs, harm reduction programs, working with marginalised communities, violence prevention. We also have done a whole series of webinars looking at the same thing, where we search the world for innovative programs addressing these issues that, as I say, should be public health issues, should be dealt with in a public health way. That's not to say this is not an argument for abolition of police or for defunding police. I'm not in that camp at all. This is an argument for rebalancing how we respond. Police have a critical role in responding to many of these issues. It's just that we shouldn't be relying on them as the default approach. Law enforcement research, I want to say a quick word about. A lot of police I talk to distrust research and don't like researchers. My answer to that is, and they say it's because their experience with researchers, the researchers don't give them anything practical that they can use that makes their job better or easier. My answer to that is you're dealing with the wrong researchers. The traditional matchup is with criminologists. Criminologists are seen to be the natural research partners of police. I don't agree with that. I think criminologists are there to research the social construction of crime and police themselves and police behaviours. I think that police are dealing with the same things that we public health people are dealing with, and the natural partners of police are public health researchers. I hope that's contentious, and I hope somebody picks me up on it. I'm nearly finished. The Global Law Enforcement Public Health Association, we run conferences, which I'll talk about in a minute. We also have formed an alliance with the Journal of Community and Safety and Wellbeing, which is a Canadian journal, originally now international, but was started by a group of ex-chiefs of police in Canada. And we had in 2022 another approach to looking at healthy and safe communities, alternative approaches to and innovative approaches to addressing public health issues in that journal. Now, in the time that I've been doing this, I've been really interested to find that getting the law enforcement and public health sectors together, the challenges are more on the public health side than on the law enforcement side. I immediately have to qualify that by saying that public policing and law enforcement is the most variegated sector. So I'm not generalising. I'm not saying all police. As I said before, a third get it and a third will never get it. The third that get it, though, make great partners and are really looking for alternative ways to approach the issues, the very complex, wicked issues that are thrown at them. Public health, on the other hand, organised public health is not interested. What do I mean by organised public health? Academic public health associations, up to the World Health Organization. I have a running battle with different parts of WHO about the need for them to be involved with law enforcement. I know the head of mental health in WHO in Geneva, and I've beaten a path to his door a number of times. And I've told him this sort of thing about the need for engagement with police. And he says, that's very interesting, Nick, but what's it got to do with me? And I say, well, look, in at least 90 of the countries you're dealing with, there's no community-based mental health system. So when somebody has a mental health crisis, it's the police who have to handle it. And they do it wrongly and they do it badly, and the outcomes are bad. Of course it has to do with you. However, I made an approach to the World Health Organization bulletin about looking at this issue in low and middle income countries, and I got back a long letter, which I'm very happy to share with you, from the editorial board, which I can only say, and the editorial board of the WHO bulletin are emeritus professors of public health from all around the world, the creme de la creme. And what came back was a mixture of prejudice, ignorance, and sheer bloody mindedness. They characterised the institution of policing as maleficent. Not individual police, not individual police agencies, but the institution of police. And I had to go to the dictionary to make sure I knew what maleficent meant. And it means of evil intent. So the public health, this emeritus body of public health gurus characterised the institution of policing as being of evil intent. There's a quote from the letter. Most law enforcement bodies are perpetrators of violence to some extent, distrusted by communities and people, inspire fear, not seen as actors who serve the public good. And where did they get that from? Because the vast majority of people in most countries actually see police as acting on their behalf and as agents for the public good. So where did the public health sector get that impression from? What needs to be done? There's just a few thoughts. Form partnerships with police. Police exist in a bubble just like other closed communities. Breaking down those bubbles is one of the best ways of changing police cultures. How do you do that? It can be very challenging, but there's a number of different ways. The joint training is one good thing. There's a program called Hydra, which you wouldn't know about, but it's in something like 80 or 100 police academies around the world, and it's an immersion simulation training where police sit in a special facility for 2 days and work through a real-life, real-time situation. Now, to do that in conjunction with public health, we've got one here in the Academy in Victoria, and I think there's a couple of others in That's right. It's devised for crisis response for police, but it could easily be work for joint training between police and public health agencies and welfare agencies. The fact is, in most police training, lip service is given to partnership. They'll have an hour's lecture on partnership, but actual how do you form a partnership? How do you sustain a partnership in the community? Police are left to work that out by themselves. The International Association of Chiefs of Police gets money from the Bluebird Foundation to support, to provide scholarships to police in the States to do their Master of Public Health at Johns Hopkins University. That means that they're developing a cadre of police with MPHs and building that consciousness within policing of public health policing. There's a number of different things like that we can do to break the bubbles, but getting the public health to step up, to keep people out, see their responsibility as taking on the hard cases and keeping people out of the criminal justice industry, getting governments to invest adequately in acquired brain injury services, in mental health services, in the things that do keep people out of the criminal justice industry. And a lot of police will say it's not our job. Our job is to enforce the law. Our job is not to influence policy. The Dutch police, each year as the budgeting process comes around, the Dutch police are very vocal and lobby very publicly. And they lobby for more funding, not for themselves, but for the mental health system, because they recognise the better the mental health system, the easier their job. Get the populist politicians out of the way. I'm given to understand, and Stuart would know this better than I, but I'm given to understand that the rise in incarceration in Victoria relates to two cases: the murder of Jill Maher and the driver of the car in Burke Street. On both of just one case, parole rules were changed and bail rules were changed, and those two things just by themselves account for the largest part of the increase in incarceration. So getting the politicians out of the way, stop them acting simply on anecdotal policy. And then the last thing, and this is simplistic. We generally operate with two ministries, two sectors, a law enforcement sector and a health sector. In cabinet, they fight for their share of the budget. They get their share of the budget and they go back to their own department, and in the department they have a fight. So police, in the law enforcement side, we have a fight between catching criminals and preventing crime. Catching criminals wins. Because the populist pressure and the community pressure is greatest on catching criminals. Preventing crime tends to lose out. Same thing in health. You take the money back to the department, we have a fight between curing and caring on the one hand and prevention and promotion on the other. Prevention and promotion loses because building hospitals for children is always going to win the political debate. My suggestion, we have three ministries. We have a ministry for catching criminals, a ministry for caring and curing, and a big thing in the middle that is all about how do we promote community safety and wellbeing generally. Nearly finished. Our next conference is in Ottawa next year in mid-2025. If anyone can get there, I would love to see you there. But before that, we have a conference in Africa, which is proving to be great fun. There's huge interest in low and middle income countries because in a lot of them, they're going through these issues. They have police agencies that were built on colonial lines and are designed to keep the population under control, to the point where when COVID first hit in countries like Kenya and South Africa and Nigeria, more people were killed by police than by the virus in the early days of the epidemic because police were simply given the task of enforcing curfews and lockdowns in places like Soweto, which made absolutely no sense whatsoever. And they did so through the brutal mechanisms that they've inherited from the colonial times. So these are critical issues, how we reform policing and turn them into partnership agencies working with public health to bring about wellbeing and health and safety for the whole community. I think that's the end. That is the end. Thank you very much. I hope I left some time for questions, and I'm very happy to.
Thank you so much, Nick. That was a fantastic presentation. It's an incredible body of work that you're doing, and I think some very compelling arguments for major reform. Thank you so much, and I hope that people here will go to your conferences. I've been to a couple myself, and they're fantastic and very different to your standard sit there and get PowerPointed to death conferences. They're terrific meetings. So thank you again. We do have some time for comments or questions, so I'll turn it over to everyone please put up your hand or just unmute yourself if you prefer.
I saw a couple of hands waving and they've gone away.
Well, maybe Cameron, you might go ahead first and I'll go second. Sure, maybe I'll go.
Sorry there, Lucas. Yeah, I was just interested with police as first responders and how you would sort of help overcome the negative reaction to public health from people who have not seen public health as their role because of their turning up to mental health incidents.
I'm sorry, Cameron, I'm not quite with the question. I mean, police have been tasked to turn up to a public health incident and they've had an unfortunate experience, or?
Yes, or there's resistance from police because they don't see a mental health role as theirs, and perhaps because of that, there's ingrained resistance to a more active role in public health.
Yep. The way that all around the world, there are experiments going on, and some of our webinars and reports address this, of co-response. We have in Victoria, I don't know if it's in Australia, Stuart, PACER, is that Australia-wide or is that just Victoria?
I'm not sure, Nick.
That's the Victoria one, but there's ones in different states with slightly different models. Yep.
And different people are looking at different models of co-response. There's an International Co-Responders Alliance actually started up from the States. It's starting to bring people together. So different models of how do you have a co-response. The Dutch, again, and the Swedes pioneered this, and learning from the experience, police responding to mental health issues and having a bad time, having bad outcomes, not feeling like they're doing an effective job, having unfortunate outcomes. So they started to team up with mental health workers so that the response is a joint response between police and mental health, and a respectful response where they each know what the other's responsibility is. And they train together and they work together so the police understand their job is to provide security and safety for the person and the surrounding environment, the people around the community. Mental health people work with the person. In Netherlands, they rapidly discovered that, okay, you send out the response, things get settled down, you have to transport the identified individual to a place of safety, put them in the back of a patrol car and everything amps up again. So they started the process of psychiatric ambulances. And one of my students in Netherlands had a look at the psychiatric ambulances in Sweden, Norway, Netherlands, and I'm happy to give you that reference if you want. Unfortunately, in Netherlands, they call them psycho-lancers. And I explained to the chief of police in Amsterdam that in English that didn't sound all that good, but it works. And I think it's a question of building relationships, because as those relationships build and police and health work together and start to realise that each has got something to offer and they can rely on each other, that starts to change that perception. But Cameron, you're absolutely right. And I mean, as I say, it's generational change. It's going to take, there's plenty of police out there who've got formed and fixed opinions that aren't going to change. But we've got to start training up new generations and build. And as I say, most police that I've met went into policing to help. That may not last. They may develop other attitudes as their policing career goes on, but most of them went in to help. And if we can work with joint training at that stage, and again, I just want to emphasise that's really not the problem in a lot of cases. The problem is more on the public health side. But I don't know, did that answer your question to any extent?
Oh, yes. I suppose I was interested in the extent, maybe the proportion of police that are resistant to being more active in public health.
I think that probably varies greatly from jurisdiction to jurisdiction. I certainly know working with the Dutch police was a pleasure. And I would say 95% of them, because they've been working at this for a long time. Here in Victoria, the police I work with But then I get a special, selection of police. They're very much on board with this. But I also run across other police. I was up the country the other day and talking with an Aboriginal health worker up there who said that the police in her region, if there's 5 youths walking along the street in a group, the police will pick out the Aboriginal youth to give special attention to. I wouldn't venture the proportions, but I reckon going on the vote about the voice, I think we've still got a very long way to go. But jurisdictions, and at the opposite end of the extreme, you've got jurisdictions like Russia, where police are absolutely 100% corrupt and part of the state mechanism.
Yeah, thanks very much, Nick.
Maybe I'll go next. Thanks very much, Nick. That was, as usual, a very interesting presentation, and I applaud that it seems like your message is finally getting across. So that's exciting in that for that reason. So my question is around the Top 600 initiative that you mentioned in the Netherlands, and I'm curious to hear from you. What do you think? Why do you think that initiative works? I mean, obviously, there's some, particular things in the Netherlands that probably wouldn't work here. But do you think that when you say throw everything at them, in a sense, do you think that that's related to like tailored services for, say, young people who are coming out of youth detention, for example, or it's just like a integration of existing services? So in that sense, it would mean that there's nothing too different about young people living detention as opposed to other young people who experience some sort of disadvantage or marginalization. So what are your thoughts on that?
Look, it's good. That's a really good question. And one of the problems with the Dutch Top 600, they've not published in English. I can get you reports on the project in Dutch, but they've never published them in English. It's integration of services. They have a special post in every police station in the Netherlands whose job is to ensure that everyone coming into the station is assigned to the right service. So they take it to that level, and they have. I can't tell you the chapter and verse about the mechanisms they have, but they have consultative mechanisms. Netherlands is one example. There's other jurisdictions like Edmonton in Canada that has a program called the Hub, and again, it's the same thing about. It's a familiar process. Get all the services around the table to look at the individual person and work out a plan for each of them. But yes, in Netherlands, it's integrated into the way the services work. I just saw Haley put up mention of the Western Australian police officer who just did the Churchill. Glenn Blackwell is his name. And I think if you haven't got him already, he'd make a great speaker on one of the webinars.
Thanks, Nick.
Any other comments or questions? Nick, I do see, I think Monica Cass just asked about where to go to find some of the resources that you've spoken about today.
Can I send them to you, Stuart, and you pass them on to the group? Is that the easiest?
Happy to do that. Please, if you haven't joined our mailing list, please email myself or Claire Chiminello and we'll add you for sure.
But Google GLEPHA, G-L-E-P-H-A, go to our website, and pretty much everything is on the website.
Great. Thank you. Amanda.
Hi, Nick. Thanks for a great chat. I'm Amanda. I'm in Vancouver, BC. I think we've maybe corresponded by email at some point. I'm wondering, I don't really have a clear question, but I'm just wondering if I can get your reflections on something. So in the BC context, we have some interesting things going on with policing at the moment. So BC just got a temporary exemption under the Controlled Drugs and Substances Act to decriminalize most drugs up to 2.5 grams. You may have heard of that, and that's they're piloting it for a few years, and a lot of this is related to the overdose crisis that's happening in Canada, but overwhelmingly in the province of British Columbia. And I don't know if it's just like the post-murder of George Floyd era, but there's so much volatility in this space at the moment that even doing research in public health with police has been challenging in a way that I never could have predicted. Like, I've been in rooms with community and actually had people say to me that the fact that I would even be doing research with police pointing out that police are the primary sector responsible for the implementation of this policy. So I don't know how people would expect to understand the policy without engaging in dialogue with police. But nonetheless, their perspective is like the fact that you would even engage with police means that you're not in solidarity with community, whatever that means. And it's really just thrown me into a tailspin as a person who does research in this area and has spoken to a lot of police officers who are genuinely concerned about the state of things, who have lost people to the overdose crisis, who respond to medical emergencies on the regular, and who are in the thick of this. And so I don't really have a clear question, but more just if I can get your reflections around that, and if you're seeing that type of volatility in the spaces that you're working in, or if that's kind of unique to the North American context.
No, absolutely. It's not unique to North America. It's very, very pronounced in North America. Our president, actually, the president of Griffith, is an ex-Mountie who lives in Arlington in Vancouver. And you would not find a nicer, more gentle, more empathetic person than Richard Bent. Unfortunately, his surname is Bent, and so he's a Bent copper, but he's a lovely man. The American Public Health Association passed a resolution in 2018 at its conference condemning police brutality as a public health issue. It was like everything APHA does. It was very well researched and very well thought through and very well written, and had ended up with, I think, 8 recommendations. But the recommendations, all of which were sensible, but they were all about how do we make police more accountable. And again, absolutely unexceptional, but nothing about working with police. The same people responsible for that started a thing called the Pledge. The Pledge went round schools of public health in the US, I think in Canada as well. And what it was that if you were a public health researcher, you were asked to sign up to the Pledge, which meant you promised never to work with police. It certainly hit some Canadian universities. I saw some Canadian universities that participated in it. Back in my community health days, I did family therapy training, and family therapy. One of the rules in family therapy is if you're going to change the system, join it. You've got to join it first before you can change it. And your experience is the same as mine. Within policing is the most variegated profession I've ever run across. I've met some of the most humane, caring, committed individuals in policing I've ever met anywhere. I've met some of the biggest fascist thugs I've ever met anywhere in policing. And I said that once to a gathering in New York of NYPD and others. And I said, they're not just in the same agency, they're often in the same office. And a voice came from the audience, sometimes they're in the same car. And I thought, what would you be like if you were a police officer who wanted to do a good job and you partnered up with a fascist thug who wants to? It's not universal. It is more pronounced in the States, and I think fed by social media particularly, but also by the racism that's inherent in the institutions and the history of the institutions. And I think that goes to Canada as well as the States, even though Canada is somewhat less far down that path than the States. Amanda, I don't know what the answer to your question is. Research with police as opposed to on police is absolutely necessary. I've been accused of, I spent a lot of time working with heroin users, and when I was doing research in HIV and Hep C, I would employ current heroin users and train them as outreach workers, peer outreach workers. And I got accused of police as suffering from the Stockholm syndrome because I spent too much time with the heroin users that I became sympathetic to them. Now I work with police, and my friends in the drug users unions and so on see me as a turncoat because I'm working with police. We actually published an article out of the work in Asia called Sleeping with the Enemy, because that's how the community saw us working with police. But I come back to that thing, if you don't engage, you don't change.
Nick, I think we're going to have to get you back. There's clearly more than enough for another webinar at some point. I'm mindful of time, though, and I see Robert's got his hand up, so I think we have time for just one more question.
Okay, thank you for that. Robert Shaw from Centre of Aboriginal Studies at Curtin University. I've just started with National Drug Research Institute this year, so I'm just starting some research around substance use and contributing factors to Indigenous incarceration. I missed the very first part, so you may have touched on this already. I'm just wondering, any of your research that has sort of dealt with First Nations over incarceration specific type of projects?
Stuart's a better one to ask about that than I am. I was about to say the answer to your question is no for me personally, except that when we were doing the studies with drug users, we had cohorts of First Nations people in those cohorts. The other mob that we are allied with is the Justice Reform Initiative, Robert Tickner's, and they're probably the more active focus on decarceration of First Nations people than we are specifically. Robert, we're not that active in Australia. We're much more active globally. It's not for want of trying, it's just the receptiveness in Australia has been somewhat less than it has been in many other countries around the world, for reasons I'm not sure that I completely understand. Clearly, what you raise is the major issue, and it's this major issue in Canada and in the States and in New Zealand and all over. I'm sorry, I'm not answering your question, but the answer is no, I have not had anything directly.
Right. I mean, I'm just interested in the reduction of incarceration of, people in jails in Europe, for example, that you've mentioned. And some of the programs I've looked into have had excellent outcomes, such as reducing recidivism from 54% down to 4%, like the Bard College program out of New York in their prison system. So I think that's inspiring that they're able to bring down incarceration numbers like that. So something must be working.
Absolutely. The problem in the States is that, and I think here in a lot of jurisdictions, is that you'll have smaller projects, pilot projects, or smaller projects that are hugely successful. It's the translation from them into social structural change that fails. That's where we seem to fail all the time. Going back to my community health days, we would start a program in my suburb with the police, hugely successful. Then government funding priorities changed, or police were rotated on, or whatever, and the learning wasn't there. The learning didn't go upwards. The learning wasn't generalised. I think that's the real challenge. How do you take that learning to the changing social structures?